Great. Well, now that we have everyone here, we'll go ahead and get started. So thank you all for joining for Grand Rounds this morning. I'm going to begin, as usual, with our land acknowledgement to remind us that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. And before I introduce our presenters for this morning, I want to send out good vibes to all our pediatric residents who are doing their final exams today and tomorrow, and hopefully will be joining the fellowship soon after that. So good luck to all of you. Our presenters this morning, so we are fortunate to have another panel presentation this morning. Again, one of my favorites to hear different perspectives on common and important pediatric themes. So our presenters this morning, this is not necessarily the order they're presenting, but I'm going to present them in the order I have them here. The first is Dr. Simone Kortstee. Simone is a pediatric clinical psychologist and neuropsychologist with special interests and experience in brain behavior relationships. She's worked in various pediatric healthcare settings in Ontario, the US, and the Netherlands. She was a member of the 22Q11-2 clinic at CHEO. Currently, where she gained her knowledge and insight in the neuropsychological and social emotional development of children and youth with microdeletion syndrome. She has worked on various clinical teams at CHEO since 2005, including the neuropsychology team that serves children with 22q11.2 deletions and microdeletion syndrome. You have to shorten that name. Currently, she is a member of CHEO's Project ECHO team on child and youth mental health. Clinically, she works at the Kuzavik Inuit Family Health Team and in her own private practice. Our next presenter is Dr. Lillian Lai. Lillian is a pediatric cardiologist and member of the Division of Cardiology, Department of Pediatrics at CHEO in Ottawa. Her training includes a Master's of Health Administration from Ottawa, MD from Queen's University, pediatric residency in Calgary, followed by pediatric cardiology fellowship at CHEO. Lillian also completed a one-year cardiac ICU and MRI fellowship at Boston Children's Hospital, and then she joined CHEO in 2005. Her main areas of interest include cardiac MRI and e-consultation. Dr. Jonna MacCormick is a pediatric otolaryngologist in the Department of Surgery at CHEO. She completed her ENT residency in Halifax at Dalhousie and subsequently completed pediatric ENT fellowship in Buffalo State University of New York. Jonna has worked at CHEO for 25 years with areas of interest in newborn hearing screening, swallowing dysfunction, and hypernasality. And finally, we have Mark Zucker, who is going to be leading us off. Mark is a general pediatrician in the Division of Pediatric Medicine and medical educator in the Department of Pediatrics at CHEO Ottawa. He is former chief of that division as well. He received his medical degree from Queen's University and completed his pediatric residency training, also at University of Calgary. Dr. Zucker has been the director of pediatric undergraduate medical education for the Department of Pediatrics since 2008 and is currently serving as the interim director for pre-clerkship Anglophone stream at the Faculty of Medicine. His clinical interests include hospital-based pediatric medicine, as well as the care of children and youth with 22q11.2 deletion syndrome. And with that, I'm going to hand it over to Mark Zucker to lead off the presentation.
Thank you.
On to you, Mark.
Thank you. Well, thank you very much for having us. We're super excited to be here today to present to you a few perspectives on what I believe is a very important syndrome and one that I have a lot of interest in, as do my colleagues here today who have joined me as well to speak to you. And we're going to give you a little bit of insight into 22q11.2 deletion syndrome and also think about what the microdeletion is. We're going to talk about the name for this syndrome, which has been a very difficult historical path. And then we're going to describe a few of the clinical presentations that we can be featured with this syndrome. We have Dr. Kortstee, who's going to talk a little bit about the neuropsychological and social-emotional development for these children and youth. And then finally, hope that you're going to be able to be aware of and think about using some of the recommended clinical surveillance tools that are available for this group. And finally, I think the overarching theme here is to highlight to you that we actually have a consortium here at CHEO looking after these children. And so get you thinking about us when you see these children and the expertise that you can tap into. So really have no disclosures. So let's talk about the history of 22q11.2 deletion syndrome, and so where it came from and where all these names came from as well that a lot of people throw around and think about. So if you actually go back deep into the literature, the belief is that there was this article by Sezokova back in 1955, and then again repeated information back in 1967, came out of actually Czechoslovakia. So a lot of people didn't know about this, but described this group of children with hypernasal speech, and then noted that there was maybe some lack of facial animation and thought maybe there could be some innervation problems. And when they've gone back and looked at these articles and looked at the images, they actually do look like kids who have 22q. And at that time, sort of velocardiofacial syndrome, when they looked at this, was sort of a name, and we'll get to that as well. Many of you used the name DiGeorge or DiGeorge syndrome. And that comes from DiGeorge himself. He was a pediatric endo in Philadelphia, and he described these newborns with congenital heart disease, an absent thymus, hypoparathyroidism with associated hypocalcemia, and an immune deficiency. And that same year, after he published his sort of case series, another pediatric endo called Kretschmer, who was in Mexico at the time, actually referred to a similar case series as, quote unquote, DiGeorge syndrome, and that was published in the New England Journal in 1968. Both of these people sort of presented DiGeorge, as we'll call it, as an abnormality in development of those branchial pouches in the third and fourth pouch. But at the same time, there's this other individual called Kaler, and they described a group of infants who had asymmetric crying faces and congenital heart disease, and said, well, let's call this Kaler syndrome while we're at it. And then also there was a Japanese article in 1976 where this team described a bunch of kids with clonotruncal heart defects and distinct facial features. And they said, well, let's call that CAF-S. And you're like, okay, well, that's interesting. And then really what we came down to was then Sprinson himself, and that's another name for this syndrome, put this all together and said, I think we should call this velocardiofacial syndrome, but some people actually attached his name to the syndrome. Velo for the velopharyngeal insufficiency, cardiac because there's cardiac involvement, and they noticed that there was these distinct facial features. And when Sprinson himself went back and looked at all these articles and presentations of the case, said, there's a lot of similarities here when you look at actually the images of these kids. And so this is where we see these names: DiGeorge syndrome, Kaler syndrome, CAF-S syndrome, velocardiofacial syndrome, Sprinson syndrome, and how do you collect this all together? I wanted to speak to quickly about the DiGeorge sequence itself. So we use the term DiGeorge syndrome, and I think we're maybe mislabeling a little bit, because DiGeorge this is actually a sequence. When we think of the heart, parathyroid, thymus disorders, it actually is that sequence can be associated with many different disorders. And I've listed a bunch here, of which the most common association is with velocardiofacial syndrome, which I'll get to in a second. And so I just want to highlight this because I think people use a lot DiGeorge syndrome for this population. And I think we're maybe mislabeling some of these children, and they don't actually have the DiGeorge sequence necessarily with their presentation. So, whoops. So what's the breakthrough? 1992, 2 articles come out in the literature, one by Scambler, who happens to be part of the 22q Foundation Organization Advisory Board now, and sort of said that, hey, look, velocardiofacial syndrome is actually associated with a deletion in chromosome 22. And Driscoll in the same year presented saying that, there's actually this microdeletion in 22q for these kids who are called DiGeorge syndrome. And so we discovered that, in fact, 22q11.2 deletion was actually the underlying etiology for all of these different syndromes that have all been labeled with different names. And so I think today, one of the big messages I think we want to get across is, and I believe we should be using the term 22q 11.2 deletion syndrome to capture these kids, because that's what their underlying etiology actually is. And some of these kids can have similar features, but don't have the deletion. It's different. It also helps us to really think about how we're treating the population as well, and we cluster them together appropriately. So what do we know about 22q? Well, it's actually a very common condition. It's about 1 in 4,000 to 6,000 live births. We know that 90% of these deletions are actually spontaneous or de novo. It's an autosomal dominant inheritance. So once you've got the deletion, you're going to have the phenotype. We know that if you look at children who are born or fetuses with major anomalies, it accounts for about 1 in every 100 of those children will have this microdeletion. Kids sent for developmental delays, about 1 in 167 will have 22q. We also know that this population has higher rates of death, even with the same malformations as other children, but with 22q. And we also know that adults have premature death, and the median age right now is about 40 years of age that they will live to. We do believe that the prevalence, I'll add, is going to go up as people recognize this syndrome, test more people, and also as these children are becoming adults, they're having children of their own and passing this on to them, to their offspring. So let's get down to the genetics of this a little bit. So the mighty 22nd chromosome, the smallest non-sex chromosome in our karyotype, is a heavy hitter. So you lose the classic AD deletion, which we call the classic deletion. It's about a 2.5 to 3 megabyte deletion in that Q arm, counts for 85% of the deletions. And then there's a few others, and I'm going to show you the actual chromosome here in a second to know what this AD, AB, AC, BD, and CD deletions are talking about. There's about 40 genes that get removed with the classic AD deletion. There's a couple of big hitters in there that we believe have some relation to the phenotypic presentation. So this TBOX1 transcription factor, TBX1, if they do a knockout mouse of this actual gene, they have the thymic, cardiovascular, and parathyroid defects that we see in our phenotype. The COMT, or the catechol-O methyltransferase, has been implicated in the microvascular development and then the neural behavior and mental illness in this population. And then in this area, there's also the DiGeorge critical region, or the DGCR region. There's multiple of them, and they believe that that's involved in some of the mRNA manufacturing in the body. So this is what the chromosome looks like. And these A, B, C, D areas are sort of what we call the low copy number repeats. And that's where your deletions occur from. So you can have that AD, which is the entire area, gets deleted out, or we have other segments that get deleted too. Interestingly enough, there is no association between your deletions and your phenotype. So it's a complicated area of the genome that actually probably has implications on other pathways, other genes elsewhere in there. So the phenotype is very variable, even if you have the same deletion, which is very fascinating for this particular syndrome. How do we test for it? Well, many of you know we have the FISH probe that looks for the, that is mapped to the AB zone of the chromosome. But it's going to miss a percentage because, as you know, some of the kids have a deletion down in the C and D zone, so it won't pick it up. Microarray, though, will pick up everybody. And so it's if you're thinking about it, microarray will not miss some of them. Your FISH might miss about 5 to 7% of the children with a microdeletion in this area. So let's talk about what these kids present as. So this is a very typical phenotype, facial phenotype for 22q. And this image of this young man is actually in a lot of the literature on 22q, if you go, as he highlights a lot of the features. So I have this short forehead, the hooded eyes, slight upslanting to the palpebral fissures, these ears that sort of are a bit more protuberant, often have more simplistic or altered folding patterns, that prominent nasal bridge, little bulbous tip with these hypoplastic ali nasi, so they have this sort of a broader tip to them, and then a little bit of flatness in their face as well. And so that's kind of the typical, but a lot of kids don't present with these classic features, and in fact can be very subtle and hard to actually notice, particularly if you're not familiar with this syndrome. But this is who actually comes to our clinic, right? So we don't get these kids that come. So I'm going to show you a series of images of all children who have 22q11.2 deletion syndrome. So here's a little baby, clearly has had a cardiac surgery, has a sternotomy, feeding tube, but you look at her and you think, that's a beautiful baby. And hard to see maybe some of the features. It's a beautiful picture of a nice young lady, teenager, has 22q as well. I think, again, show you some of the variations in the different sort of ethnic phenotypes. Again, I think you're hard pressed. And I really like these images because it really shows you the children who have this condition. And I think really nice to see. And I've got another picture here of this young lady, Amira. You look at her and you say, beautiful child, really nice looking, some subtleties there that you might, if you know 22q, you can see, but I would say, could easily not be identified as 22q. Another nice young lady, a teenager here, beautiful photography. Again, a nice young lady. Again, if you're not familiar, you'd say, I don't really see too much, right? And maybe some family features. And then finally, this young little person who I think, again, a really nice image. And these are how our kids present. They can look like everybody else. Their features can be very subtle, and they're people. And I think that's another important message I want to get across, is that these are children with this syndrome, and they present in many different ways. And often their features, when you see them, it's very hard to notice because it can be very subtle. So what are some of the common clinical affiliations or presentations? So high rates of palatal anomalies in this group, almost all of them. High rates of learning disabilities. Almost all of these children will have learning disabilities. High number will have speech delay. As we know, there's lots of cardiac involvement. Immunodeficiency and developmental delay is very common. But let's look at this from another direction. So 10% of all patients with palatal abnormalities will have 22q. 10 to 15% of all patients with tetralogy of Fallot will have 22q. 2.4% of all patients with developmental disabilities will have 22q. You can see how common this underlying etiology is for some of these common presentations. What about some other associations? Eye, endocrine, neurobehavioral, we're going to talk about that. Developmental delay, again, more in childhood. I've got a whole list here. You can see the frequency. Very interesting. One of the greatest known risk factors for the psychotic illnesses is 22q. And in fact, it is seen as one of the first genetically sort of genetic programmings for mental illness, which is very interesting. 25% of adults with 22q will go on to develop schizophrenia. Which is a great concern to all of these families. And then we noted about 30 or 40% of these kids will have mild intellectual disabilities as well, which they have to then navigate through and with their family as well. So that's a quick sort of overview of kind of 22q and how it presents. I'm going to hand it off now to Dr. I think Dr. Lai wanted to go next, but maybe Dr. MacCormick wants to go next, and I'll stop sharing.
Might still be muted, Jonna.
Jonna, you're muted.
Okay, sorry about that. This is a population that we relate to see come through the ENT clinic. There are a lot of ENT manifestations with this population. So we start with the ears. A lot of kids have problems with fluid in their ears, and so then they get conductive hearing loss. A number of them get neurosensory hearing loss. Because of the immune deficiency, a lot of them end up with getting a recurrent acute otitis media and as well as sinusitis. They end up having problems in the upper airway, including micrognathia and glossoptosis, and the lower airway with the vascular rings, we see tracheomalacia. But what we're going to really talk about today is the issue with the palate. As Dr. Zucker said, it's almost universal. And although they can have an overt cleft palate, I would say most of them actually have more just palatal weakness than an overt cleft palate. So if we go through the anatomy of how speech should be happening, on your far left, you can see when people speak, normally most air comes through the mouth and only a small amount should be coming through the nose. So in the English language, the only three sounds that are involved in the palate being completely open are M, N, and NG, and every other sound should have some degree of palatal closure. So the palate's really important in creating good speech sounds. So when you look at one extreme, if you have something blocking the escape of air through the nose, like big adenoids or a cold, all the air is going to come out through the mouth, and that gives you a hyponasal voice, so not enough air coming out. And on the other side, we have too much air coming through the nose. Air coming through the nose like that. And then that's hypernasally, and that's what we're going to talk about today. Sometimes it presents as nasal turbulence rather than just like airflow, and that's like a rumbly sound in the nose. So if this persists and it's affecting self-esteem or ability to be understood or self-worth issues, then we start considering doing surgery on this, and that's usually somewhere around age 5 to 7 years. So we have two nasality expert speech language pathologists here, and our cleft coordinator helps coordinate these appointments. They get tested with a nasometer, which measures how much air comes out through the nose when they're speaking. So the younger kids will get just speech sounds that they have to repeat, and the older kids will repeat phrases and paragraphs. And then it's compared to normative data. And so the test is called the SNAP test that we do. And if you score 3 standard deviations above the mean, you have hypernasality. So this is just the first page of a SNAP test. There you see there's different sounds, and then you just get scored and compared. So the role of speech language pathology is surprisingly not to improve the nasality. There's really not much you can do about the nasality. If your palate is short or weak, you can't actually fix that with speech therapy. So the goal of speech therapy is to work on articulation. If someone has poor breast support, perhaps you can get them to use better breast support. And sometimes if they're louder, they'll sound less nasal, and often controlling the rate of speech. If they slow down, sometimes they can articulate a little bit better and sometimes move that palate a little bit better. One of the tests the speech language pathologists will use when they're determining whether or not someone will be a good candidate for surgery is they'll pinch the nose when they're talking. And if that nasal tone goes away when their nose is pinched, it's often a good indicator that putting tissue in the back of the nose might benefit their speech. And so when they feel that the nasality component is really the main issue with their speech, then they will recommend that they be considered for surgery. And so that's when we see them together in the VPI clinic. So VPI stands for velopharyngeal insufficiency. So in that clinic, we scope all these kids and try to look for the pattern of closure. And so when we see how the palate wants to close, we can determine where the gaps are and where they might need some extra tissue. So in this population, we tend to see the most common pattern of closure is poor lateral wall closure. So the sides don't really come in, but the front to back works a bit better. But sometimes we see the front doesn't work at all either, and there's kind of poor closure everywhere. And really, they could present with any pattern, but that's the typical. So the other thing we look for when we're doing a scope is we want to look for internal carotid arteries because we usually do our surgery right in that area. And so 25% of this population will have medial internal carotid arteries. So if you look at this little girl, this is her second scope we did. Her first scope, we identified the medial carotids, and her VPI was pretty bad then, but we elected to wait because of the arteries, and she's getting a bit better.
Bravo. Le petit coco.
So that
On
little
va dire
squirting is what you would hear for
on va dire pipa.
You see, she's almost always open there.
Bravo, on va faire un bruit de sa part.
And she has no bad lateral wall movements. It's good power movements to the central gap.
Bravo, on va compter. 1, bravo.
Right here,
Bravo.
you'll see the big
C'est un
pulsations right
bon
there.
travail. Dr. MacCormick est capable de bien voir. Joue.
This young man is on our OR list right now. He is 18 years old and he presented fairly recently. He's been very frustrated with not being able to be understood. He has very poor self-esteem. He's in high school and he did not get a co-op placement this term because no one could understand him. So he's really suffering from this nasality issue. The parents have been very reluctant to go ahead with surgery because it's a very complex cardiac condition and they've been very nervous about the anesthetic. So, but he's pretty severely
Get to the count 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And you
See,
say,
his lateral
Caesar
walls
sees
don't
the
move very well, but he's
sky.
got good movement of the palate.
Chew the chocolate cake. Shoots the shark. Baby buggy. Get to the count 1 to 10.
So when you have poor lateral wall movement, then a better choice of surgery is to put tissues into the lateral walls, and that's called a sphincter pharyngoplasty. There's different kinds of pharyngoplasties. So if you have a really, really large gap, this is a good choice, or if you have poor lateral wall movement. Now, we never have 100% improvement in the nasality, partly because of some people just don't have very much movement at all. But usually the first go, it's about 3/4 of the kids will get good improvement in their nasality, and sometimes with a bit of a tweak, you can get them up to about 85%. But the kids who have like virtually no movement at all, and the only way to get rid of that nasality would be to fill up the space entirely, but then you wouldn't be able to breathe and you'd have apnea. So we are limited what we can do. So how a sphincter works is we take the tissue from the posterior pillars right behind the tonsils. We take a flap from either side, we lift that up, and we make an incision in the back wall of the nasopharynx, and we insert that tissue in there. So you can see how it forms like a bit of a circle, so hence the name sphincter. You can see how it builds up the side walls and it pulls those side walls in, and that's what gives you the benefit in this population. Here's an intra-op picture. So you can see I have split the palate here. This is the tongue here being pushed forward, and the upper teeth will be up here. So we have the posterior pillar grasped in our forceps and are about to lift that flap up. And on the left-hand side, here's the flap lifted up, and there's a defect where it came from. And so what we'll do here, it's a bit closer shot. Here's the left flap lifted up. We're going to do an incision right across the back there and lay this flap down, and then the other side, and then close up the palate. So this little guy has some hypernasality. You can see sometimes we have to be very innovative in trying to get them to repeat speech sounds with us. So they're often quite young when we're doing these scopes, but this little guy
Red.
is cooperative.
Good. Blue. Green. Yellow.
See his
Good.
pharynx
Anything else?
never closes. There's always
Now
a gap
can
there.
you say flash?
Blue
Good,
and
like-
lateral
Can you
movement not
say-
great.
Popsicle. Chocolate cake.
No,
No,
say
you
that.
never say that. What things do you like? Ice cream. No. Pizza. Okay, say pizza. Good job. Red.
So this is the sphincter, how it looks once it's in place. You can see that the side walls are built up, and so is the back wall. This is the same little guy, and here's his palate here. You can hear the difference in his voice. It's not perfect. I don't actually tend to take videos of the ones that are perfect. I'll have to do that just for teaching purposes, but he's got a little bit of a gap, but he's much better.
Nice. Oh my goodness. Can you say shoot the shark?
Shoot the shark.
Baby buggy? You say that, baby buggy.
Baby buggy.
Hamper, hamper. Can you give me that long?
There's always still a bit of a gap there, but it's better. This little girl has had a sphincter flap done but she has very little movement anywhere. Obviously, I did not put enough tissue in there, and so she still has very significant
Can you count to 10
hypernasality
for me
there.
now?
So here's the flap here, and you see how it's a dynamic flap because we take the
Can you
muscles
say
up.
Susie
But you see
sees
there's very
the
little
sky?
movement in her lateral walls or her palate.
Susie sees the sky. Chew the chocolate cake. Baby
Big
bitey.
gap. It's hard to understand.
Hamper, hamper.
So for her, we did a different flap. This is called a superiorly based flap. So we did this on top of the other flap. So this is kind of a workhorse flap for cleft palates. So we take a rectangular shape of tissue from the midline in the back of the pharynx, and we lift it up and we tuck it into the palate. So you end up with a permanent bridge across the back of the nasopharynx. And so you see, here's her original flap here, and here's the new bridge there. And the lateral walls have come in nicely. So these are her ports. She has these tiny little ports, and that's all she's breathing through. But even with that, she's still hypernasal because she doesn't have very much movement.
Count 1 to 10 for me. 1. Susie sees the sky. You say, just repeat after me. Susie sees the sky. Chew the chocolate cake. Baby
So
buggy.
we've actually injected, taken
Hamper,
her back and
hamper.
done a little injection on either side to see if we could bring that up, and I haven't seen her back afterwards, but you can see the challenges we have. I can't make that much smaller because she's not going to be able to breathe at all. So thanks very much for allowing me to share these cases with you. Communication is so important for humans, and these kids really get isolated, they get poor self-esteem, and we're really hoping to make their quality of life better with these procedures. Thanks.
So does everybody see my screen now? Anybody see it?
Yes, we see
Yes.
it. Thank you, Lillian. Yes.
Great. Okay. So Mark asked me to speak about two specific, I have no disclosures. And as you guys have learned, there's a significant amount of heart disease in these patients, but I'm not going to speak about this because you guys already kind of know that. For people who are doing their exams, tetralogy fellow is the answer for you, as well as truncus. Interrupted arch would be the third answer. But I'm going to speak more, so just to show you, we're not going to talk about these things, but these are the more common things that we would see as a diagnosis of cardiac issues with these type of patients. Mark wanted me to speak specifically about two focused things that are going to be quite short. One is what type of fetal findings make us suspicious of 22q and what makes us want to go for genetic testing, as well as the new thing on the block, which is the talk about aortic root dilation in these patients, which has just come up in the last 5 years or so. So there's lots of good data to support the first objective for us to learn about. When we look at a fetal assessment, there's already a well-defined HA statement about that guides us as to what type of cardiac anatomies have a high percentage association with 22q, specifically interrupted aortic arch, as we talked about the type B type, which is the one between the carotids and the subclavian. And that's up to like 48% of patients with that type of anatomy will have 22q. Truncus, tetralogy, isolated arch anomalies such as right aortic arch would make us think that we should get some genetic testing. And if we look at talking about conal truncal anomalies, meaning the middle part of the heart, VSDs are very common in the cardiologist's life, but there's a very low association with 22q. So we don't typically test genetically for those patients with just isolated VSDs. We would, however, if there's an association with an arch issue, and Dwarf would be the last type of anatomy that would make us suspicious. Overall, if we are referred to see a fetus for cardiac issues, if we don't see a thymus, that's another thing to make us think that we should send them for genetic testing. So in that topic is pretty focused and quite clear. The second objective, which Mark asked me to talk about, was about this aortic root dilation. So over the last 5 years or so, there's been a little bit more talk amongst this field about aortic root dilation. And there's not a lot of research in it. It's estimated that we see it in about 10 to 16% of these patients overall. It's usually in the older population. CHOP is probably the center that came out with the most up-to-date study about this. They went back and looked at their whole group of patients with 22q up to 1992. And they looked at their echocardiograms from before over a 5-year period. And they focused only on the patients with normal hearts or just isolated arch issues, just to sort of better define this population. And they found that 16% had aortic root dilation by their measurements. 8% eventually developed aortic root dilation. But what's interesting, and I think everybody should take this as a learning point, is that people who were defined with aortic root dilation, their second echo went back to normal. So that speaks to how when we look at our echo reports, when you guys look at our echo reports, the measurements that we take, and it's important for you to explain this to families, is that you shouldn't take it to the number, to the 0.5 millimeter. There's a lot of plus or minus. And as a result, this is shown in this study that, you know, one day you're normal, one day you're not. So if you're around that ballpark area, we always should think about our measurements as a ballpark number, okay? But what they did find, however, is that male patients had a higher risk of developing aortic root dilation, 3 times more than the female counterparts. And they didn't see any association with age or presence of arch anomalies. So in their center, they actually suggest that patients 22q who have normal hearts be evaluated every 3 to 5 years just to monitor for this. Now, practically, what does this mean? Because there's not a lot of research, we don't know, but outcomes wise for you as a general practitioner who's following these patients, there's no true complications, I think, that have been reported so far with this finding. We don't really see aortic dissection as a common finding in 22q patients. The worst thing that's been published is trivial AI as a development. So I think that overall, is this an important finding or not? I'm not sure, but it's definitely something that's new. It's out there in the literature and people should be aware of that. And we do follow, we would suggest to get an echo as a screening thing every 3 to 5 years in these type of patients. So I hope that you, from my little short 5-minute thing, we know that there are cardiac anomalies that would cause us to go for genetic testing in the fetal assessment. And in the 22q patient who has normal, no heart disease, you should send them every 3 to 5 years just for a screening echo. I'm done.
Thank you. Yeah, so Mark asked me to talk to you about neurodevelopment in children with 22q. And I'm very excited about it because this is just a fascinating group of kids. And I really enjoyed listening to the other speakers because I sometimes forget about the medical complexities, but I get to deal with their everyday life and their functioning in school and with their parents and their friends. So I'm going to talk to you about this. You can look at this later. So when we think of this condition as a genetic disorder, multiple organs develop differently from the start, including the brain. So I've been mostly looking at the brain. Very quickly, I'll go over these, things that are kind of general knowledge. So most of these children have fine and gross motor delays, expressive language delays, that are often speech-based, like John talked to us about. Their intelligence is different, highly variable. If you think about what we call the normal population following a nice bell curve in terms of intelligence, so do children with 22q, except the curve is switched, moves to the left or to the lower range of functioning, about 2 standard deviations. That means that a lot of children have mild intellectual delays or close to mild intellectual delays. Also, what's interesting is that their trajectory is less stable. If we test a child at 7 years old and has a certain cognitive ability, we can kind of predict what's going to happen in the future, and that's much less true for children with TDQ. And a little bit later, you'll understand why that is. Almost all have learning disabilities. In fact, I can't think of one that I saw that didn't have a learning disability. Sometimes they don't meet the full criteria because they haven't been in school enough to be falling behind and don't meet the formal criteria yet. But the underlying weaknesses point very clearly into to learning disabilities in all, I would say. The literature, so I'm going to talk to you a little bit about what the literature says and then what I found myself. So in the literature would say verbal skills are stronger than visual skills. Verbal memory is stronger than visual memory. It would say that list learning, random list learning, is easier than learning in context of a story. In the literature, over and over again, people seem to repeat that math and verbal comprehension are weak, which is often true. It's a little bit nuanced though. Many people describe this group as having a nonverbal learning disability, but really only 20% of the children match nicely up with that particular profile. They tend to have difficulties with problem solving and reasoning and executive functions. Mental health, Marcus talked about that already. Many children develop anxiety. A large group will develop schizophrenia. The literature would say that lots of kids would meet criteria for autism, but when you actually look at it, they most often don't meet the full criteria, but definitely are atypical in their neurodevelopment. And many children have ADHD. Now I'm going to take you from the research to what we see in clinical practice. First of all, these are the sweetest children you'll ever meet. I wanted to say something very positive. These kids they're in my heart, every single one of them. They're hardworking, they want to please. They do not see harm or malice. Almost none of them. Actually, I can't think of one that actually understands or can imagine that another person may not have the best intentions. They are extremely trusting. So those are really nice features, of course, but also can be quite challenging in everyday life. So what was hard? So I started in 2003, I believe, at Sick Kids. I was asked to add a day to my work life to work with these children. So I saw at least about 50 of them together with my student at the time. And every Friday morning we would go in and meet one of these kids with their families. And what we started, first of all, like at the end of the day, we would be exhausted, more exhausted than working with any other child. Like I worked with many different populations. And these kids were puzzling. We didn't understand them. And what turned out to be the case is that we noticed that there were limits in our standard battery. Our battery that we use for all children with neurodevelopmental differences, medical illnesses, you name it. We use that. We look at levels of functioning. We look at patterns, strengths, and weaknesses. And usually at the end, we can figure out what's going on. This group, it was really tough. The results were difficult to interpret. They did not follow the typical patterns that we know about. Often the results weren't valid. So just a little bit of a sidetrack here, children with this syndrome, they tend to like sameness. They like to answer the same way. So if we ask, what does this word mean? Like, what's an apple? And they would say it's a fruit. And then I would go on, what's a chair? They may continue talking about fruit. Or if they had a multiple choice format presented to them and they said A to the first question, they tended to go on with A, or at some point during the test, they would start to become perseverative. So we're no longer measuring what we were supposed to measure. So what we were measuring was no longer valid. We had to look well beyond the data, well beyond the numbers, and we had to find through our observations what was actually going on. So what we found is, unlike the literature, we find that actually there's a lot of variability in the LDs. It's not just a nonverbal learning disability. We also saw lots of variability in intellectual abilities. We saw children well in the sometimes even moderate delays, intellectual delays. But I remember vividly a child that had an IQ 115. That's like the standard deviation above the mean. The literature would say stronger verbal, weaker visual, but what we saw was that it could really, that could change actually. There was no real pattern that was predominant, that was dominant in the population. Lots of variability in the way attention and physical restlessness presented, just in very similar to what children with ADHD present like. I think there was a lot of variability in speech articulation. So in this domain, we couldn't find a clear pattern. That's what I wanted to say here. But then in other areas, we found almost like a neurocognitive signature to these children. But you had to really look. You didn't necessarily find it in the numbers. So what we found was that the neuroatypical development that is resembling of ASD is like an insisting on sameness, liking things to be the same, fixations on highly specific interests, difficulties with transitions, difficulties with social interactions, and strong perseverative tendencies. How was it different from ASD is that it was more flighty. That's the word we came up with. It was more flighty, whereas a child with ASD has a specific interest that can last for months, sometimes years. In children with 22q, it lasts a few days, a week, and then it moves, and then it changes to another interest. So it was shorter lived, but the fixation and the intensity was as intense. We could even see it during the assessment. So if we were working on, say, putting blocks together, they could get really focused on a feature of the block and not really on the task anymore. And like in a hyper fixated way, but once we moved on to a different task, say, for example, we ask about an animal, name this animal, and the animal is a cat, then the child could get for like minutes or sometimes 15 minutes really focused on something like that. So that was we almost saw that in all children in varying degrees, sometimes very clear, sometimes we had to really ask the parents about it. Now, the next one, difficulties with relational concept, is actually the big take-home message for you. This is the most important part of my little few minutes talk to you. These children, and we could not find it in the numbers, but we saw it in the observations, had a huge difficulty with concepts like first, second, next. Today, tomorrow, yesterday. Before, after, up, down, any kind of relational concept that you can think of, they had huge difficulties with. And this is why we were so exhausted at the end of the day, because we are completely biased. Our neurotypical brains are biased towards cause and effect reasoning. This is how we understand the world. One thing leads to the next, and we try to connect the dots to make sense of it. These children either have almost none of these skills or have significant weaknesses. Of course, you will see children who can do it to some degree, but all of them had some problems there. And this means that they're kind of lost. So I'm going to keep going. So what does that mean? If you have difficulties with cause and effect reasoning, then the world becomes a confusing place. You're not able to connect the dots easily. You don't understand the consequences of your own behavior. You're not able to understand why things are happening and the concepts of why, therefore, because, and this is how we teach, right? Like we just give some information and we give the next piece of information, and then many children will connect the dots by themselves. Teacher may give some kind of explicit instruction. These children need that a lot more because they will not understand it by themselves. How does that affect academic learning? Well, these children do not learn well by leaving them by themselves to explore things and problem solve, learn by trial and error. They learn by watching others and mimicking them, doing exactly what your neighbor is doing, what your mom is doing, without true understanding. And I would say in the higher functioning kids, if they learn a lot this way, understanding tends to come after that. So when they've learned it by rote lots and over and over and over again, some understanding will emerge. So their strengths are in rote learning. They can be good at math facts. All the additions, subtractions can be learned by rote. They can learn reading, decoding skills, sometimes with a delay, but usually they get pretty good at it. And they love following the rules because rules provide consistency in a world that's confusing. Their weaknesses are in problem solving, of course, because that cause and effect reasoning is very weak. what happens emotionally. When you can't make sense of your environment, as well as your peers can, you become anxious and worried. And that's what I actually see a lot in children with 22q. Being lost in the world, not understanding the flow in communication, not understanding why things happen in this particular order. And then there's a subgroup of children that just unfortunately live in families that don't have strong structures in place, or there are vulnerabilities in attachment relationships. These children, I don't see as much anxiety, but more erratic behavior. It's not easily understood. This is common in children with attachment disorders, but I see it even more here because children have a really hard time making sense of situations that are not strongly structured and organized. Later on, as a result of missing social cues and ambiguous language, nonverbal expressions, they are at risk of being left out, leading to anxiety, loneliness, and some symptoms of depression. Behaviorally, okay, so I have to be careful here. Behaviorally, I can't explain everything just based on that cause and effect reasoning, but to some degree, you can imagine that the insistence on sameness, for example, wanting things to stay the same, having a predictable routine that you know that you've learned by rote is very safe. It feels very secure for children who cannot problem solve in the moment. So there's more to it, but I would say some of this insistence on sameness can be explained by this. So how do you teach and parent? So I just have 2 slides with some pointers that you may be able to use in your practice, but also maybe share with families that you're working with children with 22q. So really beware of your own bias towards cause and effect reasoning, which is really, really hard to undo. It's really, really hard to understand how children, without this frame of reference that we have, make sense of the world. Provide strong, predictable routines. Routines allow for a feeling of safety. Warnings and support before change happens is crucial. Help a child reorient when routines are changed. I want to give you a little bit of an example. There was a kindergartner, JK, who had adjusted beautifully to the JK classroom and was moving to the SK classroom. And she had learned where the cubbies were and what she was supposed to do. She walked into the next classroom and the cubbies were placed at a different wall. She had no idea what to do. So there was no generalization. She could follow the rules in a specific environment, but not generalize them. So this tells you there is no connecting the dots going on here. But teaching explicitly will help this child to adjust to the classroom. Visual schedules and verbal reminders, of course. These children need to have tasks broken down in very small steps, teach step by step, teach by rote and not by problems. And you parent, typically we all have consequenced our kids for behaviors. These children may not always understand that the consequence to their behavior was actually connected to their behavior. So you have to really rethink that. And better ways of teaching are modeling, role-playing, repetition, and redirection. Gentle and reassuring tone of voice. Be patient, these children are so confused already. And any kind of raising of voice will just make that worse. And of course, that'll affect executive functions right away. Every skill should be taught through direct instruction, explicit teaching, also skills that we typically don't teach that way. Like, for example, getting on a bus, teaching what you do when the bus breaks down. Very explicit, practical teaching of those kinds of skills. And whenever you've taught a skill, it needs to be, you need to teach the generalization to other environments. I can talk about this forever, but I want to leave some space for questions.
Okay, thank you all. That was an amazing presentation. I've learned so much about this this
Still
syndrome.
got some more to go. Still got some more to go.
Oh, yeah, okay, all right.
2 seconds. We're just going to wrap
All right.
it up.
Okay, go ahead, Mark.
Can you see my slides?
Yes, go ahead.
So I think what we just wanted to end with was to recognize, there are management guidelines out there for this population. This is probably one of the most recognized guideline that you can find. It's from the journal Pediatrics, and it goes through sort of some approaches to helping to manage these kids. The recommendations are systems-based, and you can see that there are a large number of systems that need ongoing and regular monitoring. And that basically, I put this chart in here to show you that, and these systems all need monitoring on an ongoing basis through all ages, through childhood and into adolescent and into adulthood. There are 17 items you actually have to do a diagnosis with these kids. There are 14 more or continued at preschool, and 11 at adulthood that need ongoing. And in fact, there are different guidelines for different countries, so they're not all consistent based on, so some are on opinion. I really like this graph to show you the intensity of need of these kids over time. And you can see a lot of cardiac involvement at the beginning for many of these kids. But then really interesting is that learning behavior and psychiatry becomes a huge part of what we do for these kids into adolescence. And some of the other issues remain constant throughout their lifetime. And I would say that's the experience in clinic as well, that learning behavior and mental wellness is the main focus for teenagers. A couple of ideas around advocacy and recommendation for management is coordinating their care by key worker. And this is to highlight that that's what we're now doing. So a pediatrician, myself, sort of trying to coordinate the care for these kids, developing local expertise. And I think we're showing you today that there's a lot of local expertise on this population. And I think we're continuing to develop that. We're managing transitional care to adults. There's the Dalgleish Clinic, Family Clinic for 22q in Toronto. It's a world-renowned center for adults with 22q that we're referring our kids to for ongoing transitional care, which has proven to be very valuable. I would say virtual care has really helped us with that too. They advocate that having a social worker to support and advocate for the family. We don't do this consistently through our group. We utilize the social worker support so we can find the hospital, but we don't have someone dedicated to this population per se. And then we are working on a personal health record for these patients. While it's recommended, many don't keep it. And then to highlight, there's a management guideline for adults now that have come out for this syndrome. And this is out of the 22 clinic in Toronto. And just to show you, I just put this in to say, there's a lot of stuff that continues on into adulthood that these people need, and there's actually guidelines for those individuals, including things like contraception, family planning, genetic counseling, and then things like money, finances, vocation. All these things are where they need support. So my final slide is just to say we have developed an area of expertise here at CHEO. We do run what I consider a consortium of services. We don't have a clinic, as in people come to one clinic and see all of us. We really do it by affiliation and by connectedness. And I think we've really created some expertise in key areas, and we're continuing to expand. You've only seen a smattering of the individuals at our hospital involved with these kids today. We have a whole nother group of people that are helping us with it as well. If you have a patient with 22q that you would like to access our services, send me a consult in Gen Peds. I do provide the quarterbacking for the care for these kids, and I'm happy to have them sent and provide some value added to their care. I will not take over their care from you in the community. If you're sending them in, I will help you with the care of these kids. And we do this as a team. And we've got some suggested readings for you as well in this presentation. And now we're open to some questions.
Thank you, Mark, and thank you, team. Unfortunately, we don't really have time for questions unless there's a very brief question, a quick question. You were very comprehensive with this presentation, and when you showed the list of all the different disorders or the related medical problems, that you could have had a huge panel here actually presenting on this disorder. So thank you very much for that. The presentation is archived, so all the resources will be available. If anyone has questions, please go ahead. And I guess Mark is probably the best point of contact to coordinate and quarterback referrals for this disorder. I think it's really exciting, and I think the more of these that where teams come together around a condition, I think it really is the best for patient and family-centered care, and it really helps us to stand out as centers of excellence. So thank you very much for that for the excellent work you're doing and for presenting to us today. Thank you, Mark, for all your leadership on this. I agree with you, Jonna. Very good point.
Total team effort, everybody. Total team effort. We all do equal bits.
All right. Have a great day, everyone.